about cataract, can please step out and enjoy yourself outside. We're going to talk serious business of retinopathy of prematurity. Okay? And I have with me a galaxy of stars who are all specialists in ROP. Dr. Anand Vinekar, Dr. Dogra, Dr. Jalali, Dr. Parijat Chandra, and Dr. Karobi Lahiri, who will enlighten us on the problem of ROP in this country and how to best manage. I'll probably kickstart the process by talking about risk factors, examination techniques, and screening protocols. Because the hall was given to us 15 minutes late, I hope they won't object for us to spill over 15 minutes more. Thank you. So the topic I chose to talk is on risk factors, screening protocols, and examination techniques. Can I request you to close the door, please? Yeah, so before we talk of ROP, we should consider what are the risk factors for premature birth itself, because if that is something you can prevent, you prevent the entire gamut of ROP itself. I understand that that is outside the purview of ophthalmologist's capability, but there are factors which could be potentially controlled. And we, I know, are not directly involved but have significant vested interest. I sincerely hope that somebody from that specialty will be able to help us in reducing our workload. Coming to ROP itself, there are lots of factors we know of. The major risk factors we all know are gestational age and birth weight, which are standalone factors. In fact, based upon which even all the screening protocols are framed, 1500 grams or 30 weeks of gestation and above. Oxygen, of course, has been identified as an important parameter. A lot of factors have come out in various studies based upon what they call as univariate analysis, which is not important. It's multivariate analysis which is important, which adjusts for other factors. And then you find that most of these factors found on univariate analysis have dropped out. And what was found even on multivariate analysis are certain prenatal factors, perinatal factors, comorbidities, and others. Postnatal weight gain and IGF-1A levels have been promoted as important parameters in the Swedish study. You got patients who are outborn first month of pregnancy nutrition, and specific to AP-ROP were neonatal sepsis and chorioamnionitis. It's impossible for me to go through the details of each one of these factors, but just suffice it to say that in a given situation, there may be more than one factor at play in causing ROP. The recommendations by AIO and AAP for screening, our standard recommendations are infants with a birth weight of less than 1,500 grams or 30 weeks of less gestation period, but anybody with a cardiorespiratory support requirement, even beyond 1,500 grams or 30 weeks of gestation, are eligible for screening. Now, in India, we do find patients who have never had cardiorespiratory support, delivery was in the house or in a village, and yet developing ROP with possibly 2,000 grams birth weight, although the birth weight itself is a question mark. Whether it was really weighed correctly, we do not know. So the recommendations for timing of examination is based upon post-menstrual age more than chronological age. But if you understand that any child who is born beyond 27 weeks of gestation, you follow chronological age of 4 weeks after birth. Below 27 weeks of gestation, you follow the post-menstrual age of 31 weeks. Now, it doesn't harm us if you examine 4 weeks for everybody, so that even if there is a AP-ROP, you will not miss it. So probably it is better to follow the idea of Dr. Subhadra that examine all patients at 4 weeks after birth, irrespective of their chronological age and postmenstrual age. Of course, it does add more numbers to your examination numbers, but I guess it is worth it. Now, there are various models which have been created to help us to identify which is the group which is at risk of developing ROP. They are based mostly on gestational age, birth weight, again, all those parameters which we identified on multivariate analysis to be important. But none of those have really been proved to be so useful that you depend only on that to tell us which case to be screened and which case not to be screened. We still end up examining all children at the age of 4 weeks after birth in most situations. Now coming to examination techniques, I would divide into prenatal preparation, infants preparation, and surgeon's preparation. Prenatal preparation, I would prefer to have the parents wait outside, which I have not been able to enforce in most situations, because the mothers especially, they cannot bear to see the child being examined by you with indentation, with a speculum and all that. And some of the mothers can actually faint just by seeing the examination. And also, it makes it easy for you to teach your fellows or somebody in training to do the examination, because they don't want the same child to be examined by 2-3 people. So they actually object. And brief them, of course, on the need to use a speculum and indentation, because the post-examination you will find the marks seen on the eyelids, that also they're worried about. Little bit of subconjunctival hemorrhage they're worried about. Infants preparation, there's no feed required, should be given 30 minutes before examination, because they can potentially aspirate. Mummy restraint we are aware of. ECG leads are not needed for a routine examination unless the child is in NICU, already the patient is being monitored. Pulse oximetry is optional for an examination. This is mummy restraint, which everybody is aware of, but just to re-emphasize the point that each hand has to be wrapped separately. Both hands are not put simultaneously underneath the blanket. Otherwise, by separately folding it, the child cannot actually bring out the hands, Pupillary dilatation, there are lots of regimens available. A mixture of 2.5% phenylephrine and 1% tropicamide is the most commonly used. In India, we have only the so-called Tropicacil Plus, which when you dilute it, it becomes 2.5% phenylephrine and 0.5% tropicamide, which is okay. A mixture of tetracaine with 1% phenylephrine and 0.5% tropicamide also has been used by one particular group. Cyclopentolate is available in the Western countries made by Alcon, but for some reason is not marketed in this country. 1% phenylephrine with 0.2% cyclopentolate. A micro drop is also been mooted as the best way of dilation, because it is equally effective but safer with no change in the heart rate or BP noted, because the amount of drug that goes through the NLD is very little. A micro drop is just 7 microliters versus 26 microliters of regular drop. Tachycardia is seen with 2 anticholinergic drugs, so you never use cyclopentolate and tropicamide together. You use that with phenylephrine. There are several events reported with dilation, including cardiovascular effects on BP, heart rate, etc. But most of these are not seen when you don't use cyclopentolate, the feed intolerance, ILS, and NEC. But yes, phenylephrine can cause raise in BP and heart rate with 2.5%, but with 1% you don't see the effect. So ideally you should use 1% phenylephrine with maybe 0.5% tropicamide. The preparation of the examiner doing the ROPI examination, full sleeves should be rolled up, no wristwatch, no rings on your finger, no long nails. Because all these can harm the baby and also transmit infection from one baby to the next. Hand scrub before touching the child, make it a routine. The choice of speculum, we got these 4 speculums currently used, of which the Cook speculum has the least trauma to the child, because the amount of spreading of the eyelids is entirely in the control of you, not spring-loaded. Alfonso speculum gives you very quick widening of the eyelids, but can be very traumatic to the child because it really yanks the lids apart. So if it is possible, you have both Cook speculum and Alfonso speculum with you and use it as you require. Follow a set routine. I always start with the right eye, irrespective of which side is accessible to me, so that I remember in which eye I saw what. Because at the end of examining both eyes, you can get confused as to which quadrant is having stage 3 and which eye is having the plus disease. So follow a set routine, finish the entire right eye, start with superior, nasal, inferior, temporal, then go to the left eye and do the same thing all over. Easiest is to start with the temporal periphery, because that's where you're likely to see the disease first. Scan the entire fundus, not just the periphery, because you may miss actually retinoblastoma sitting right in the mid-equatorial region because you're concentrating near the ora serrata. Examine with and without indentation and examine, The reasons for an inadequate examination are poor pupillary dilatation, a hurried examination because you have to examine a lot of babies and you're in a hurry, unstable systemic status where the child desaturates or is becoming apneic, then you stop examination or you're not able to examine properly. The inexperience of the examiner is perhaps important, because when the pupil is mid-dilated, the extreme periphery or mid-periphery, sometimes they are having difficulty in examining. So there are babies who have been labeled as normal and having actually a serious stage 3+ disease. The complications are apnea. I just take only half a minute. Apnea and desaturation, conjunctival hemorrhages, corneal abrasions are all very, very simple. But sometimes I have seen patients who are having actually a polyp, developing a hemorrhage right in front of your eye. You indent and release. The release process produces a burst of bleeding from an elevated polyp. So when there's obvious polyp, please don't indent. It's not required. Okay? Now there is a stress to the parent. Of course, the missed ROP is the worst complication of examination. Follow up very quickly. 1 week or less, when the disease is very posterior, immature retina in stage 1 or 2, an AP ROP suspect. Follow 1 to 2 weeks, if it's unequivocally regressing ROP in zone 1, but immature retina in posterior zone 2 are a stage 2 disease. And follow up for 2 weeks is for a stage 1 disease in zone 2, immature retina but no ROP, or an unequivocally regressing ROP. And of course, 2 to 3 weeks and beyond is mostly zone 3 disease and beyond. Okay? So when can we stop ROP-oriented examination? Zone 3 vascularization, especially when there was no preceding zone 1 or ROP or zone 2 ROP. That is, the retina is normally getting vascularized. It reaches zone 3, it's unlikely they will ROP. But somebody had ROP in zone 1 or 2, then even when it reaches zone 3, you should be cautious. A full retinal vascularization up to ora serrata, these degrees is mandatory for us to declare the child as normal. Thank you very much for your attention. So next, Dr. Anand will talk about lasers in ROP. Dr. Anand, please.
Thank you, sir. Thank you, sir. I'll go on to the lasers in ROP. No financial disclosures. So ROP laser is still the gold standard. More than 90-95% can have a successful outcome. We're looking at better 6, 12 or better even after 3 years or more. Which laser? I think if you are using diode, it's time to switch over to green. Dr. Dogra's group showed this several years ago, maybe serendipitously, but green works much better and has much less myopia as well because the scars are not as deep, and you can really have, in fact, you can see vascularization going on into the lasered bed. As sir has also already mentioned, swaddling or mummification is really important. Use a linen cloth that's not very stretchable, and of course, as mentioned, keep the 2 hands separate. Keep 1 foot out so that you can put on the pulse oximeter. This is for laser more than screening itself. And if you've really made the baby nicely warm, you should be able to rotate the baby on the back, on the rump of the back, because that's how nicely you can look at it. Dimming lights is optional. I would suggest you start getting used to doing laser with fairly good amount of light in the room, because you can pick up a lot of apnea. You can even pick up the baby going blue and cyanosis. Oral analgesia along with topical anesthesia is accepted now, and both in the NNF and the IROP guidelines. 24% sucrose if available, more easier to get a 10% dextrose. Topical anesthesia is what most of us do all our lasers on, with the exception of it's a very large baby or for any other comorbid conditions that you need to do it under general anesthesia. The disadvantage of general anesthesia is only one, of course, other than the fact that you're giving GA, is that you may not be able to go at 6 o'clock to laser at 3 o'clock, and the tube is, the ET tube almost interferes with that. Or in all other conditions, you can either rotate the baby or rotate the trolley under topical anesthesia. Positioning the baby, different heights, all of us come with different heights, and the table, unfortunately, doesn't always cater to that. So the most ergonomically best way is to keep 1 palm length below your umbilicus, and a supine baby, the nose should be at that level. With that, you get the best view of zone 3, and you will not miss anything, and also it will really help your back because you need to keep it preserved. This is from a chapter I had the good fortune of co-authoring with Dr. Capone in terms of the dilator drops, procaracaine, all of that has already been mentioned. Don't count the number of spots. It's like the dosas that you eat when your mother prepares. The job has to be done. You cannot leave any avascular retina remaining. So if you see the ridge in 6 clock hours, but there's avascular retina in the other 6, be assured that you must laser the avascular retina as well. It's not only about dealing where the ridge is. A small pupil, a tunica vasculosa lentis, is not the only indication for anti-VEGF. You can get good dilatation if you just simply dilate, massage it well, and if you just have to examine the baby once, 360 degrees, it becomes all right. This is a little more easily said than done, that you avoid dense treatment over the long posterior ciliary nerves, but keep that in mind when you're doing it. And when you depress, especially babies who have a stage 3 slightly raised, when you undepress, when you sort of release that very cautiously and slowly, because if you suddenly depress, that's when you may get a lot of hemorrhage, especially in a vascularly active stage 3. Again, as Dr. Dogara's group has shown, you can treat these babies even if they are sick and dependent in the incubator. So don't allow your neonatologist to tell you that I'm delaying screening because the baby is sick, because it's the sickest babies who have the worst disease. And even if sometimes you see a lot of anasarca, which is very low protein in the blood of these babies because they are sick, a lot of them have chemosis even if you've been very gentle during your lasers. And for this, you need to move around the chemosis, otherwise it can really preclude the view of your laser. Now, I'm going to give you some case scenarios here. So aggressive ROP, of course, anti-VEGF may be the first line of treatment today, but there are conditions where you should know what is the principle of doing laser for aggressive ROP. And you either have to laser on the flat new vessels, or you laser up till the new vessels and wait for the vessels to retract. And this was shown in the photo ROP group. Macula sparing ROP is sometimes you, even though the case may be very bad and you cannot give anti-VEGF for many reasons, we'll discuss that in the next talk. You must evaluate, and when you see these, a lot of prolif, especially in the nasal zone 1, but aggressive ROP in the temporal area, be thorough in your laser, but you can still avoid lasering the macula. And wait, and if you've done a good thorough job, more often than not, these blood vessels will eventually vascularize into that part of zone 1 which you have left behind. You'll spare a lot of zone 1, they'll have much better outcome, obviously lesser myopia as well. So these are, I'm just going to run these images fast for you to show you that a lot of follow-up later, they do extremely well if you, and you can spare macula in many of these conditions. Now, the hybrid ROP, although not a separate nomenclature in the new ICROP3, we see it all the time, where you see fibrovascular proliferation, classical stage 3, along with aggressive ROP. Now, here you are worried about crunch, especially if you're seeing these babies a little late. If you're seeing at them 39, 40 post-menstrual age, you're scared that if you give anti-VEGF, they will detach, and rightly so. So here you must have laser in your armamentarium. Here's a classical case of very bad hybrid, zone 1 fibrovascular proliferation, almost in a 39-week. So here you know that anti-VEGF may be dangerous. So here you must know how to do the laser thoroughly again. But the difference between the first and the second laser is sometimes you might have to get into, you may not always be lucky sparing the entire zone 1. So you can see that crescent-shaped area here that you have spared in the first laser sitting. You need to go back there and do it. If it is gray, bald, shows capillary non-perfusion. And also within the layers of the fibrovascular proliferation seen nasally, if you're able to laser here as well, look at how angry this plus looks even after your laser has been put in 2 weeks later. But just 1 week after that, this is how it will look, just 1 week after. And that's the advantage of taking care of all the ischemic elements, even if they mean in between fibrovascular proliferative issues, as long as you're sparing. So ideally you want to be at least 2 disc diameters from the center of the fovea, but if you can't, so be it. Now, this is a very, very important topic, laser persisting avascular retina. So here is a zone half with the capillary non-perfusion, as you can see in the FA. Here we've given anti-VEGF. I'm going to move really fast. 2 days after Avastin, 3 days after Avastin. This is a 2009 case, right? So at that time, we were not even sure how to follow up these babies. Let's go quickly to 10 months. This is 2 months after the anti-VEGF. This is 10 months after. Now, most people will now, at this point, declare the baby to be completely normal and let them go into the community, and that's where we are going horribly wrong in India, because a lot of these babies are turning up with late recurrences, detachments, and blindness, and you will be medico-legally liable. Now, in these cases, 10 months later, as you can see, this is now clearly defined in ICROP as 2 disc diameters or more of avascular retina, 10 months after injection, where otherwise everything looks normal. And if you go back and look at the clinical picture, you won't even realize, perhaps, that there is avascular retina. And you must mark out this area and laser treat it, otherwise it's not going to do well. This is, we are in the end of, by the end of today, hopefully the Indian ROP Society would have come up with its guidelines, but this is something that we wrote out. These are 6 possible reasons that you have to think about when to do laser after anti-VEGF. They are not perfect, they are not guidelines yet, but we promise you before the year ends, we will publish the guidelines as well. So response, recurrence, vascular growth beyond zone 1, at least wait for it to go to zone 2. Post-menstrual age is important. At least wait till 48 weeks. That's when fovealization should happen. Systemic conditions, please correct anemia. And important reason in India would be loss to follow-up. If the mother simply can't keep coming every 2 weeks, you can't tell her, by guideline, I have to see you till 65 weeks. It doesn't work. Now, finally, posterior laser. I'm just going to end quickly. There are 3 rules for posterior laser. When do you do it? You do it when there is stage 3, when it is more elevated than 1.5 to 2 disc diameters of fibrovascular proliferation. You want to laser posterior to the, so we always traditionally knew we had to laser the avascular retina, but now there's a concept proposed and published by Anna Els about 10 years ago now. So there are 3 rules. Firstly, you want to go at about 1.5 disc diameter, 1.5 times the width of the fibrovascular proliferation. If this is 1 dd, you want to go up till 1.5 dd up till here. Then why have I gone all the way here? And that's because the second rule is you want to go up till the base of the avulsion. If all these blood vessels are avulsed from here, if you go to the base, that's when you will flatten all of this. And third one is you want to be at least 3 disc diameters away from the center of the fovea. That's easier said than done because some of these babies don't even have the fovea developed at the time when you're doing the laser. Now, important thing, cover that up fully. Laser in between those avulsed vessels, but don't hit the vessels, you can bleed. And then when you go back and look at that, it completely heals without any fibrosis. We have now long-term follow-up. We'll publish it shortly. They have very limited myopia, and they have excellent vision as early as 2.5 to 3 years corrected age. And then finally, laser to avoid 4A. Either you're buying time because of systemic GA conditions, or patients are not agreeing, or maybe it's limited disease. So here again, posterior laser comes in very handy. And here you might want, so this is temporal and nasal. I'm sorry, I've cropped it to show you how both of it happens. So while the temporal one completely resolves, the nasal side may not completely resolve, but may be restricted in terms of exudation and traction, and maybe you will be able to avoid surgery. So the signs of regression, 1 week later, you must look for pupil dilating and good media. And after 2 weeks, the ridge completely flattens. And by 4 weeks, if you have not seen complete response, then please look for areas that you might have missed out. Right, and finally, as a summary, cover all avascular regions, even beyond where it is in the ridge. Plan PAR, it's a new concept. All of you who are injecting must have the ability to also do laser, because your babies are going to need laser in more difficult scenarios when they are much heavier and much older. And finally, posterior laser. Thank you so much.
Diksha, who's here with me. So this, you can see hardly the vessels are there. So ILIA was given here. So this is 2 weeks, 5 weeks after, and you can see 9 weeks after, and in 16 weeks after ILIA, and 56 weeks of post conceptual age, you can see, I think, what she has done in angiogram now. Now look at it. This was like a posterior zone 1. The vessels have gone beyond. That is what is important. And now, once the vessels have gone beyond, you're not going to sacrifice that much retina. You're going to preserve the posterior pole, and you can very well laser at this stage. So this is at PCA 58, the reactivation is seen and the laser was done. And what about the treatments between bevacizumab and ranibizumab? I think there are now clear-cut lot of studies, in fact this one, which is in fact recently, last year published, that ranibizumab, this is our experience also, was associated with higher rate of retreatment than bevacizumab. The retreatment group had a larger percentage of, this is very important, which was being asked, I think Anil Gangu was talking to me, that aggressive posterior ROP will have more number, 34% versus 18%. That is what, and this is statistically significant. And the greater percentage of zone 1, still it is not that bad as compared to aggressive posterior ROP. That what is, I think, very important, this thing from, even the meta-analysis are available now. The laser was associated with lower rate of retreatment than ranibizumab in type 1 ROP. And while bevacizumab was associated with lower rate of retreatment than in zone 1 ROP. That way, ILIA, if you use aflibercept and bevacizumab, I think they both do almost close, but then the ILIA, again, it's not logistically possible for us to use, but the bevacizumab has other issues that people are scared of infection. Because at this time, one of the issue is that the only drug which is approved, and it is a biosimilar by DCGI, is biosimilar, and which is being given under Janani Suraksha Yojana in most of the hospitals, free of charge. And so we need to generate more data on that, and that is what is very important for us. I think this one I want to project, which in fact I have been showing for quite some time, right from I think World Congress in also Mexico I had shown. This was an injection was given, the laser was performed. So don't sit on this that you are done. No, it's not like that. You are done if only laser is done, what Anand showed. It can have a problem like this. You may have, that is the mistake which I did that time. I thought it looks nice. I called this baby back after 6 weeks. And by that time, it happened. So you can see that is why I want to say, if you have given an injection, even after laser, be careful. So don't let them go. Keep a close watch, and that is very important. I think role of anti-VEGF in surgery, I think we have here Parijat and Praveen and others. They have also shown in other groups. I think this case again shared by Diksha and Zone 1 APROP. Look at how proliferation, very vascular. Now what to do here? I think that is the way it became after injection. Then she did quick surgery, both eyes, sequential, but you see, still you could salvage even in a situation like that with lens-sparing vitrectomy. So anti-VEGFs in ROP have become more acceptable all over the world. We used to first kind of talk, and we had those, but most would use in APROP and Zone 1 ROP that I have shown. And anti-VEGF injection may be followed by need for less extensive laser, which again I have shown here. And eyes treated with anti-VEGF should have a frequent and long-term follow-up that you don't forget. And these baby grow up, sometimes it is very difficult. And it may help to preserve more healthy retina in visual field. So I think we'll have more data on that. So thank you very much.
Well, we come to the next talk by Dr. Subhadra on the management of stage 4 ROP. I'm keeping the time for possible discussion at the end, so let us have some questions ready towards the end.
Hi, so how many of you are just itching to do stage 4 surgery? Great, that's wonderful. I know that there are many who are already doing, so I'm not asking them to raise their hand. So let's go and see like what is the big issue. So the first thing to remember is that the retinal detachments, stage 4 and beyond, they can be various types. The highly common is the tractional detachment. So these are not reg detachments, so they don't need any tamponade or laser to a break. So you don't need to do a retinopexy for a break. Few of them would have an exudative component, and we should know how to manage that. More recently, we have started recognizing that although regmatogenous detachment in ROP has been described in older children, but as you saw Dr. Dogra's case, sometimes they can come back with combined RD even in the acute phase, and this has not been much talked about in the literature. Almost all of them are bilateral, very rarely we have unilateral. It will start within 2 to 3 months of age. Of course, if it's aggressive, zone 1, hybrid, it will start earlier, and it can have various configurations. The configuration mostly decided by whether there's a persistent fetal vasculature stock on the disc and which is acting as a scaffold and closing the funnel. So differential diagnosis should be kept in mind. We've had patients where actually it's a viral retinitis, or it's a toxocara, or there's a fungal candida abscess, or a fungal ball inside, which has been mistaken as a ROP. So remember, it's a progressive disease, unlike your tractional detachments of diabetic retinopathy, which can take ages to become worse. The vision and the potential for vision progressively decline day by day. So these are emergency cases in most situations. So there are various approaches to the surgery, and we can have various things, but most important, which I've highlighted in yellow, is when not to operate. So there are patients who come with sort of stage 4, which is already in the cicatricial stage, it's already silent. And how you detect that is that, number one, the media is clear. There is no vitreous haze when it goes into cicatricial stage. And we have shown with our studies that this vitreous has actually a lot of inflammatory mediators when it is active. So if you don't see each vessel clearly, then you can think that this is going to worsen. The other is, of course, the pupil dilates very well and very easily. But of course, the configuration of retina also you see whether the vessels are silent, and then in those cases we don't do any surgery. So belt buckle, this case Dr. Gopal operated many years back after I had done laser in a one-eyed child. He's now a university postgraduate. You can see that, the retina is dragged towards one side, but there was no persistent fetal vasculature stalk. The funnel was open, and only in the periphery there was some traction. So a belt was put, and after a year it was released. And this boy is using telescopes, magnifiers, and he has decent vision. Notice the disc cupping. Recently he has had raised pressures and he is on timolol controlled. So we need to follow these patients. All these ROP patients, they can develop glaucoma, and we publish glaucoma after ROP surgeries. Now these are tractional detachments, so the funnel was trying to sort of close down and the patient has come a little late, and we put buckle, belt buckle, and the posterior retina then opens up. So these are cases where there is a peripheral traction, about 4 to 6 clock hours, and the disease has sort of died down, then you can do belt buckles. So I have recently, started doing sclera imbrication in few of the cases where there's a combined tractional and reg RD or a bad tractional RD. I'll show you one of the cases, this case from Dhaka. So normally we would have done a lensectomy, vitrectomy, or a nasal side partial vitrectomy to reduce this disease. You can see it's very active, but we just did a buckle, and that's how the whole thing has improved. So there would be limited indications for some of them. But the most common indication for lens sparing vitrectomy is something like this, where you see the retina is sort of lifting up, and it looks like it's going to be silent. When I saw this patient, I thought, okay, the macula is spared, it's just a little bit of nasal thing, I'll just add some laser and see what happened after a week. Still I was happy. And then 5 days later, see what happened. So that's what I'm trying to say, it's very active, it's aggressive. And you can see there was media haze here all over. We could not see each vessel clearly. So that was an indication that it's going to worsen. Of course, we operated and got good outcome, but if we had operated at this phase, then it would have been much better and there would not be that much of drag and CME. So this is the time that you should send for surgery if you're not doing yourself. You saw the patient has aggression, you did the laser, and you see that some area is lifting off. This is the time to immediately check the hemogram, give the transfusion. 90% of these babies are anemic at that time. Their hemoglobin is 7, 8, and then refer immediately. And we can do a 20-minute surgery, and everything becomes very good. And there's no traction on the retina, and things become good. So that's the advantage. So there are various forces which we have to cut during surgery. I'm not going to go to all the details. These are technical details. But main thing is we don't want to touch the lens. We don't want to touch the peripheral retina or create a detachment, and we want to remain in this trapezoid area where we can just cut these membranes in the vitreous and get it back. So I hope this video will run. So this is sutureless vitrectomy, where we are just putting a bolster of the 240 band here so that the amount of trocar inside the eye is less. I pull the conjunctiva on the cornea so that I can deposit it back and do a sutureless surgery. We don't need to do, you can use 23, you can use 25. And most important is that when you're putting these cannulas inside, make sure that they are well placed. You can see here this cannula is sort of little loose. And this is what happens during surgery. It can come out and create a choroidal, or it can touch the lens. Or when you're doing fluid exchange, the air will come into the AC and lead to glaucoma later. So this is very important that all the cannulas should be properly placed. I keep this cotton wick in all cases to drain away all the water from there. And so then once you've done this, put the 3 things. And mostly we make the horizontal incisions at 3 and 9 o'clock. So we are not worried about damaging the ciliary vessels because we are quite anterior. This is 1 to 1.5 millimeter from the limbus. And the whole surgery is done with good guard connection of your vessels. And then when you go inside, you need to break all these drag areas. So I'm just going to stop here and go to the next one. So I just wanted to highlight here that if you see that the retina is pulled up, or you see an opacity in the periphery, that means that retina is pulled up there. Then you cannot enter through that area. Then either you have to enter nasally, or you have to sacrifice the lens and enter the lens. So this is the most critical part of surgery in stage 4B ROP. So then, of course, you can have other types of detachments, like a bleb-shaped detachments, which we have described. In these cases, you need to act very fast. You need to give anti-VEGF. Within 24 hours, you need to do the laser of the peripheral retina and get them to the table. So the outcomes of these are sort of moderate because these are really fulminant cases and these are cases who've come late. But still, you can get decent outcomes if you follow the triple attack on these eyes. You can also have exudative RDs. So most of these RDs don't need surgery. They look very horrible, but once you give the anti-VEGF and do the laser, they do pretty well. So the most important thing is if you have done surgery in one eye and not done in the other eye, they will develop transient anisometropy, a very severe anisometropy. You can see here both eyes had laser, and the one which had surgery, it went into high myopia -4, -11 within few months, and the other eye slowly went, and by the time 2 years they were all same. So this anisometropia is very important for you to do the patching, give that management. So if we operate the eyes, we start the amblyopia therapy right from first week post-op. So this is just to show the joy of seeing somebody who was labeled as going to be blind, the vision rehabilitation, the glasses, the myopic correction or the aphakic correction, and then patient wait. The outcomes of these surgeries should be assessed at 3 and 4 years of age as far as the visual acuity is concerned, not at 6 weeks or 2 months. The retina takes time to go back. It takes time for the vision to develop, but your persistence leads to really good outcomes. Thank you.
About the management of stage 4. Now,
Part of this course, and it's a pleasure always to speak at this IC. So I'll be talking about management of stage 5 ROP. So first question which comes to your mind is, which cases should I operate? So the ICROP3 gave a very good classification of stage 5 A, B, C and divided stage 5 into 3 parts. So stage 5A, when you get, basically optic disc is visible on ophthalmoscopy and it's an open field kind of attachment. So the question which comes to my mind when I see a case like this, can we make this outcome better than what it is now? So many times you might not be able to make it better than what it is now. The lens is a very important component of the refractive status, and if you have to go in, you have to eat away the lens, and then the patient will become aphakic and mostly will become amblyopic. So if you cannot make it better than this, the macula might be attached, might not be attached, there might be shallow RD there, the disc is visible, then it might be better to leave it sometimes. Again, stage 5B, optic disc is not visible, little 5 places is there, and this huge closed funnel situation is there are no anterior segment changes. So again, you have to think the same thing, can I make this outcome better? So mostly these are the cases which are operated where, just like people like you who are operating PVR D3, you know that if you open the central membrane, the things might start to open up as you progress into the funnel. So sometimes these cases might open up. So these are a good situation where you want to go in and try to open up these funnels. Stage 5C is a different game because mostly the anterior segment gets involved in these cases. And so if you see on the left side, the top left photo, again the corneal opacity is there. So many people like to operate in 2 sittings. In the first sitting, they want to, remove the anterior posterior synechia, clear up the cornea, then wait for 5-6 weeks, and then go in for a second stage surgery. But many people like to go in for the photos which you see on the bottom left, where it's mostly like a 5B only. The moment you open up the synechia, it behaves mostly like a 5B. So it depends on how you want to go in. So again, the question you should ask is, can I make this better? If you can make it better, then you should give it a try and go inside. So basically 5ABC is a continuum of disease which basically is progressing from different stages, and as it gets worse, the complexity of the surgery becomes difficult and the funnel continues to close and anterior segment changes come into the picture. A word here about cases which come in stage 5 at an early stage. So here, they have not really stuck behind the lens, but they are coming at low PMA, let's say around 45 weeks, 42 weeks. When it's gone into stage 5 ROP, these are vascularly active and they're progressively closing up. So these cases are even more difficult to operate because there's a high chance of intraoperative bleed, post-operative bleed, and the disease might continue to progress despite your surgery very actively. So these are much more tougher cases to operate than burnt out cases coming to you at 60 weeks or 70 weeks PMA. So I'll talk about the surgical technique. So the SN group has given a very nice idea about the different tractional forces which are there. And if you see here, this is how the traction tends to proceed and progress into stage 5 ROP. So people who want to start stage 5 ROP surgery should understand the pathoanatomy of how the stage 5 ROP is happening, and then you can progress further with it. A lot of this will depend on how much anterior peripheral access do you have. Is the posterior peripheral access available or not available? Which will decide your approach. You want to go clear corneal or you want to go through a scleral approach. So many people like to do a UBM here in this situation to find out which area, is particularly the thing is not stuck. In those areas, you can try a scleral approach if you want to go in. Or maybe that lens is not involved, it's pretty low TRD. Again, you want to find out where you want to go in through a posterior approach. So if you just want to go through a posterior approach, then you you do not want to insert the trocar completely, as has been shown by Madam earlier as well. So you do not want to go in fully. So I just put in half the trocar and then I slide the rest of the canal in so the trocar does not go and hit the retina in these situations. However, in most of the cases, it's all stuck behind the lens. So this is how I go in through this approach. So this is a 23G MVR which is going in, through which 25G instruments go in. So this allows for a snug fit as well as mobility of the instruments. So 3 ports clear corneal incision is made, and then you can go inside. So now you're going to do a lensectomy there and remove the posterior synechiae. So now you have this dense retrodental membrane which is sitting there. So in an area where the retina is not stuck, you look for a clear area with the endolight, and there you can create an opening in the retrodental membrane. So you see there's so much opacity is there between the fovea and the light source. So all these opacities have to be removed in between. You see we have not cut the iris. The iris is a very important component. We should not spoil the cosmesis of the eye. And you can then continue to eat away all this tissue in the periphery and cut with scissors, etc. and continue to dissect into the periphery and open. So here you see a central open approach. We haven't gone into the periphery much. But you see as you continue to eat into the central part, this I'm just trying to show you here. There is a last bit of tissue which goes out, and there if you see, there you can see that the disc will be there. So there you can see the disc is there and the posterior pole is there, which is almost very shallowly detached in that area. And then, after doing all that, I like to hydrate it, and then we'll just inject it. So it comes a sutureless closure, and air is injected in the end. And because it's an MIVS system, it does not leak and holds on. Obviously, there's no ego about this. If you've done a lot of manipulation and the wound leaks, then you should go ahead and suture it. So a lot of the funnel access, the posterior funnel access, a lot of it depends upon that. And as Dr. Gopal has also very nicely described in his article, if you go to very narrow funnel configuration, it's a risk factor for a poor outcome in these cases. So if the funnel opens up very nicely, then you can have a better outcome than a funnel which, does not open. And obviously there's a learning curve about this, and people who get started into this need to learn about this. So is the USG actually useful? So I'd asked Dr. Tracy this, he said, it's of not much use, and I just go in every case and I try to do it. So you can try ultrasound in initial cases, and these are open configurations you might find easier to operate initially once you get started, rather than getting stuck funnel which is totally closed and it might demotivate you. So it's better to start with an open funnel. So this is another case to show you that it opened up like this. As I showed in the earlier case as well, the posterior funnel opened up very well. So this is not a common outcome. This is a rare outcome. I'm just trying to show you that these babies are left for blind, and as Dr. Jalali also highlighted earlier, Dr. Gopal also highlighted, we should go in for this surgery for these cases. You don't know how much the funnel opens. Once you go inside and continue to open, it might continue to open. And of course, a lot of these will be like this also. So what I want to show you here is that a lot of these cases have been operated stage 5. You see they are in different levels of opening. They are in different levels of contracture. They might or might not look good to you. But the important thing is here, all these children have mobility. They can walk from here to that door without crashing. A child who has so much opacity in between will just have a PL plus minus. These children have some kind of high movement, some kind of thing which will allow them to go from here to there, to the toilet. They might be able to see a parent is standing there. They might not be able to see their face exactly, but might be able to see that this is my father, this is my mother. They might see there's a chair here. And this changes the life of the child, changes the life of the family, and empowers the child. So sometimes, it might not be stage 5 ROP, although it appears there's a lot of, things stuck there. And once you go inside, you might find that it's actually a stage 4B sequelae, which you just opened up, and suddenly a large part of the retina appears to be attached. So here, just trying to show you, you open this up, and a large part of the peripheral retina appears to be, attached in this case. Just a central TRD is there. So that kind of surprise might happen. The important thing is to expose the macula, and this can get exposed in a large number of cases, although it might be detached. So once you get it, it's better not to, ruin it, not to, do too much dissection there, so that, the macula might be thin, might be cystic, might already have a pre-existing hole. So better not to, just let it go away. The benefit which you got for opening the funnel, better to prevent the reclosure of the funnel rather than, creating a macular hole. And the standard teaching is if you get a break, you close the case. So I never close the case even if I have 2 breaks, 3 breaks, because there's no intention. So what I'm trying to show here is, you see I'm doing the same thing, and the dialysis happened in the periphery. You can see a lot of subretinal fluid is coming out from the top right side. So I don't stop my case, I continue to do it because it's a last ditch effort for this child. You are even not going to laser, you're not going to put oil, you're not going to put gas. So you're not going to make any attempt to, settle this. So I continue doing this case, and it doesn't interfere with me if it's dialysis happens in the periphery or break happens in some particular part. So I continue with that. I don't stop the case. A lot of people use adjuvants to remove the vitreous membrane. A lot of people use viscoelastics to do it. I don't use it because sometimes it can go subretinal and it might further create problems, and I might not be able to remove it completely. But a lot of people like to use viscoelastics and staining agents, and it helps them to operate these cases. So you can also try that, and it might work for you well. A small tip before you close these cases, what I'm trying to show here is that everything looks fine. So I just pinch the cannula, and it starts to bleed. So these are bleeders which are not happening because of the VGFI. So if you pinch it, the bleeders come up, you then dithermize them, because they are not appearing to you when you are right now in the middle of surgery, but they are there. So the moment you take out this cannula, this is going to bleed and everything is going to get spoiled. So right now we're in the middle of surgery, I'm just pinching it and you see this is happening. And just the last 1 or 2 slides. So improving closure, if you're not going to get good gain, at least don't mess up the cosmesis of the eye. It's better not to eat away a large part of the iris, better not to mess too much with the decimates, create coronal opacities. I like to do it sutureless. Obviously you can suture it at times if you want it. So this helps in a good cosmetic outcome. Even if the child sees something or does not see something, don't mess with the cosmesis of the child, which reminds the parents every day that something happened with the child. And I think this is the most important of all these, whether you operate or you don't operate the child, and whatever little the child can get, it's best to keep that with the child. So this is very important. Visual rehabilitation, I think, is the very most important part. Even if you operate, you don't give him proper glasses, he's going to become amblyopic. So all the benefit is going to go away. And even a child who's, let's say, in stage 5A has some kind of vision, better to rehabilitate them, empower the child, and also empowers the family and the society. So thank you so much.
I'd like to thank Dr. Parjat for telling us where you can do stage 5 surgery and still benefit the patients to some extent, although the thing is very frustrating. Dr. Karubi will talk to us about the controversies, and after that, if time permits, we'll have a short discussion.
Everybody, thank you, Dr. Gopal, for including me in your course. Today I'm going to talk about controversies and the management of ROP. Now, I just make a list of few controversies, and some of them have been touched upon so ably by people who have spoken before me, so it makes my task more easier. Now, who should screen for ROP is a burning question, whether it has to be an ophthalmologist, whether a tele-screening personnel, certain pediatricians, who can do the initial screening, but the need is the ratification has to be done by a trained ROP specialist with a binocular indirect ophthalmoscope with dilatation, with an indentation of 20 or 30 diopter lens with a depressor. Because can one miss the disease? Yes, if a person is inexperienced, is in a hurried form of an examination is done, obstruction or discomfort from tubes and gadgets while examining, excess light in the NICU, non-dilating or purely dilating pupils, and a very sick infant requiring a hurried examination. These are all the deterrents for a good examination, and you may miss something, like scenarios like this where there are only tubes which are seen around the patient's eye. Now, second controversy is about the dilatation. Dr. Gopal has already told you that the best combination is phenylephrine with tropicamide, and I'm not going to go further into that. And as he also mentioned that the microdropper is a good idea to do it. When you put the drops, you can do punctal occlusion, and you can turn the head of the patient away while putting the drops from the site of the opening of the fornix. And you can use mid-reasserts, lower conjunctival fornix packing can be done. And vaporized tropicamide applications on eyelids margin or phenocaine is another option which you can give topical, which helps the dilatation. The stage 3 is the staging of the disease. There was a study by Campbell et al., and they had reviewed 1553 eyes where they found a whole lot of controversy was there regarding the classification, pre and plus classification, in the zone classification, and in the overall staging. But the only thing which was consistent was that 95% were on agreement on the zone 1 disease. Now, the thing was diagnosing plus or pre-plus. Now, ICROP3 classification still recognizes plus as a continuous spectrum. Type 1 or type 2 definition is still based on labeling the patient as a plus or pre-plus, and there is no guideline as to the management of pre-plus. So what are the suggestions given? If one eye has frank plus, then veer towards plus. If the eye needs a surgery for a systemic indication, treat as plus. Have shorter intervals between examinations for better conclusions. The next controversy is whether it is zone 1 or zone 2. So there are certain characteristics. Now, ICROP3 has included a posterior zone 2 and the presence of that to address several disease states which are prominently in that particular zone. But still, you have certain areas, zones, where you find that it may look like a zone 1 disease or a classic disease, but actually it is, the deterrents were whether there was a notch, whether it was coming into the zone 2, transgressing into zone 1. And the other things were whether it was an AROP versus classic, because there are sometimes patient looks like an AROP, but actually is a classic disease which benefits from a laser treatment. Now, several other types have been postulated. The hybrid ROP, which Dr. Mangadogra has and associates have highlighted, it combines the classic with an AROP affecting heavier babies in zone 2 with a better prognosis. The incomplete vascularization or immature retina is a new terminology which addresses severe forms of type 1 disease like half-zone ROP, where the arcades may not extend beyond 2 disc diopters from the optic nerve with no definition of the macula. So these are several prototypes of the same thing showing this kind of disease, and you have to determine what you want to do as treatment for these disease. Now, who should treat ROP? Whether it is a trained ophthalmologist dealing with ROP, trained VR specialist dealing with ROP, whether it's a trained VR specialist not dealing with ROP, pediatrician screening ROP, and we know of certain pediatricians even giving injections for ROP, whether it is a resident training in ROP, because we know that there is inadvertent misuse of anti-VEGFs, whether indicated or not. So suggestion is that have a person give the injection, a person who knows how to laser, when to laser, how to adequately laser. So this is about who should treat. So these are certain cases where you have to decide what treatment you're going to give, which form of treatment would work best, whether you want to give a laser anti-VEGFs or whether you want to go in for a surgery straight away. Now, controversies would be where anti-VEGF versus laser is the first choice of treatment. So this also has been covered very well. And the thing is that it is important that you do not give up seeing these patients or just postpone the intervals, because in that interval, you might result in problems. So you have to follow up these patients carefully till you see it till the end. Now, controversies again is what to inject, when to re-inject, when to laser, after injection. When to inject has been addressed already, so I'm not going to go into that. But when to re-inject is another controversial situation because it depends on the half-life of the drug that you have used. Now, ranibizumab has a very short half-life and bevacizumab has more. So as it was stated that ranibizumab, the need for giving the injection is generally more, the prevalence. And in bevacizumab, many people do with only 1 injections, but the peripheral avascular retina is more in the bevacizumab group, and the amount of peripheral avascular retina has been seen to be less in the ranibizumab group. So you have to know when to combine the treatment, how to observe, which patient has to be followed up, and if there is reactivation, definitely go and treat the patient immediately. Now, the peripheral avascular retina is again something which I'm not going to touch because Anand has spoken about it very ably and nicely. And the laser treatments, again, 1 session or multiple sessions has to be decided. How many shots per session, what take care to take, what areas to avoid, that is the ciliary vessels, you just avoid those areas. Now, treatment at 6 and 12 o'clock are generally a little more difficult. So all you can do is elevate the chin, use a shoulder pack under the shoulders of the child so that the neck is a little extended. And the thing is, treat from the diametrically opposite portion because you can shift the babies and the trolley. And you can do it in the incubator also, as you saw Dr. Mangadogra doing it. And when to say no to a stage 5 surgery, again, this has been addressed very well by Parijat. Scleral buckle, definitely still an option as Subhadra has shown you. If there is a falciform fold which is completely stuck, then don't do anything, leave it alone, because the patient uses the residual vision when you rehabilitate for his ambulation. If it is got a pup tent kind of traction, you release that traction with your surgery so that a greater portion of the retina goes back, so it helps in the visibility process. Late referral, if it is completely closed, do not touch it because it's not going to yield anything. If there is a break during surgery, there is a need to tamponade. Yes, if majority of traction is relieved, you go ahead with the surgery as Parijat showed you. And if there is a resurgery, it is possible in 5% cases where you feel a small adhesion is there somewhere, you can just go and release it and the retina goes back into place. And when to rehabilitate? Early rehabilitation is most important, because in a preterm child, there are several areas where the child has to be rehabilitated right from the time that the child is born in the NICU itself. And medico-legal issues. This is one aspect where there is no controversy. It is just document, 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 and treat as per guidelines effectively, aggressively, and early. Thank you so much for your kind attention.
Thank you, Dr. Karabi. I think we have been given the hall 15 minutes late, so we can take 15 minutes more, right? Yeah. So we got 15 minutes for discussion. If there are questions from the audience, yeah, go ahead, please.
How to identify clinically, I mean, most of us don't have access to FFA based on imaging, so how to identify clinically in old babies? My first question, and my second question is to Dr. Parijat,
Identify what?
that if you leave the peripheral phase, how important is to dissect it, because they don't allow the retina to settle in the peripheral phase, so how important is that?
So, persistent avascular retina doesn't require an angiogram to diagnose it. Clinically, it can be done. You have to, of course, have the, you need to look for it. So, you will have to depress the baby. It cannot be done otherwise, speculum and depressor. Since it's a majority of the time in the temporal quadrant, just depressing there, one could do it. You will be following up these babies after anti-VEGF 2 weekly or 3 weekly, depending on the protocol of which injection, which drug you have given. So you will also know till where the blood vessels have reached. So that has to be documented on the file. And 2 disc diameters is actually easy to make out once you've looked at the aura. And what we are hoping to come out with guidelines is between 45 weeks and 55 weeks, somewhere midway, you might need to take a decision on whether you can do the laser or not. But the outer limit would be 60 weeks, at which point if there is PAR to do the laser. And this is the consensus that's building up. And as I mentioned, we'll hopefully publish it as guidelines soon.
The only point I would like to add is that between 20 diopter and 30 diopter lens, if we want to depend only on visual observation as to where the vascularity stops, a 20D lens is better. A 30D lens sometimes you may not be very clear. Dr. Parijat, you would like to answer this second question?
So you're absolutely right. If you leave a large frill, it's not going to settle. So it again depends on how much the retina is attached into the periphery. If you've got a good peripheral access, then it's a very good idea to remove as much as possible and let it fall back. Again, it depends on some surgeons. Some like to go from center to outwards. Some like to go from outwards to inward. It depends on that. But if the whole thing is absolutely stuck on the side and you're not able to relieve it, then better not to tatter the whole thing. So it depends. Best to obviously do as much as possible so that traction can be relieved.
So there was one thing which I wanted to mention. You spoke about how to do a fluorescein angiography if you don't have the access. You can resort to an oral fluorescein dye, and instead, if you don't have a machine, then you can just see it with your blue filter on the indirect ophthalmoscope. So it gives you the information, but the documentation will not be there.
And we have recently shown that you can do this on your Claris, you can do on our Optos, so you can do your angiogram even on the adult machines. So there's no, if you really have to do it, although it's not necessary as said. See, we just need to see is there leak, so you only need to see the late phase. You don't need to see the early phase and choroidal phase and all. What you need to see is the last phase. So that will come if you do it at 10 minutes.
Okay. Yeah, please.
Thank you, sir, for this instruction course. Learned a lot. I have a question regarding stage 5 ROP. You've done a good dissection, maximum possible. You've done a lensectomy already. You've done a air fluid exchange.
No, so air fluid exchange is not done. Air is just injected into the AC in the end to close the ports. That is the main idea. So hypotony is not there post-op. The ports are closed. If I said if you can do sutureless, very nice because 25G instruments have 25G MV openings are there. But even if a lot of manipulation is there, it's still collapsing, then there's no harm in putting a suture also. So usually it's not left hypotenuse. Eye is not left hypotenuse. And fluid is there behind. Air is injected to help close the ports.
So if the retina is coming forward, that means there is a break somewhere. Otherwise, whatever you open, it will be left open. Very rarely you may have to put some viscoelastic to push it back. But in general, if things are not going back on their own, they're all floating up, that means there is a break somewhere.
There's also a situation where there may be too much of exudative component, where I find sometimes the retina doesn't permit you to dissect properly. Then you can actually drain the fluid from behind, and it allows you to give space, working space. It's not like flattening the retina in a rhegmatogenous RD, but it allows you space to work if it's exudative RD. But otherwise, as I said very rightly, the other thing is that suturing is not a bad word, okay? So if you have difficulty in maintaining the eyeball intact, I don't mind. I use 10-0 Vicryl these days because it's absorbable and doesn't hurt the baby as much as 10-0 nylon. So one single stitch of 10-0 Vicryl can close a limbal wound very nicely. Even a scleral wound can be closed with a 10-0 Vicryl pretty well. Yeah, thank you. Yes?
We are doing the combined therapeutic answer. Post-injection, is it disease-specific that we should wait going for laser or it is surgeon preference?
Yeah, I think that comes back to what's the preferred guideline. So ideally, we'd want the vessels to grow at least till zone 2 or wait for the current weight to be more than 4 kgs or the postmenstrual age to be more than 48. Each of these have been chosen for basic science reason. 4 kgs because of insulin growth factor causing the vascularization to proceed. 48 weeks because by then fovealization should have happened and technically the periphery should have got vascularized. And zone 2 because the primary reason why you gave injection and not laser in the first place was to protect as much of zone 1 and zone 2 as possible. Now this is in theory. Sometimes the blood vessels don't grow forward. There's especially posterior zone 1 simply remain at zone 1. And that's where the problem comes, whether you will re-inject or whether you will do the laser. So I think the consensus building is re-inject only if there is a failure to response, and that we will define. And in all other cases, follow up and eventually do laser.
There's also a protocol that we have published, and Dr. Dogra also showed that protocol. Now, if you think a priori you want to do a combined treatment because you know that this is a zone 1 disease and he already showed 80% of them are going to need laser. Tapas has also shown that if the rate of growth of these vessels is low, they will need laser ultimately. And we have also shown on OCT that some of these OCT biomarkers can tell you they'll need laser. Then you can you give the injection, after 4-5 days the pupil dilate, you can do the peripheral laser and leave the posterior pole and then follow. And in follow-up, if you find that is not grown at 60 weeks or something, then you can add laser posteriorly. But you've already done very good laser in the periphery. Only caveat is if you do laser in baby who's still 26-27 weeks at the time of your laser or 28 weeks, what we have shown published is that the anterior retina can grow even after that. So while you may have done laser, there can be recurrence because new retina grows because eye is still growing. So you may have to touch up that area also. So the protocols for combined treatment are also published where you still spare the posterior pole.
I think if you believe in combined treatment, please don't do both on the same day. Yeah. If you do laser and then inject, the systemic absorption becomes more because you've broken the blood retinal barrier. Okay?
At least 4 to 7 days.
And in bad case of AP-ROP, sometimes you may have to plan all the 3, laser, injection and surgery. So you know that child will definitely require all the 3. Yep, you have some question?
In case of non-compliant parents, so we inject and most of the cases do not turn up. Should we prefer deferred laser or should we go for second injections?
I think that is very important, I must say. In case the parents are not going to come back, you have to counsel them well. Anti-VEGF only after thorough counseling. If they are not and you have doubt, do laser in such a case. Otherwise, it's a problem. Because, of course, we did laser all our life. But in such a situation, laser is indicated. Anti-VEGFs can have a lot of issues if they are not turning up. They may come suddenly later on with all the problems and it might go to
Also try to find if there's somebody closer to them who can take care. So we are having this issue. They'll fly from Delhi and say, you only should treat. When we tell you have to come 5 times, they say, no, we can't come. Then don't have that ego. Tell them, okay, there's a PGI, there's a doctor there. Please follow and to get the laser done there. So.
Any other questions? I think we have already taken 10 minutes more of this hall time. Probably we'll hand it over to Professor Azad for his next
The
course.
next session is
Next
also
course
on ROP.
So you can continue to enjoy
urge you to
the
stay on.
feast about ROP. Yeah. I would like to thank all my co-investigators. Thank you.